Hi, in this unit we're going to talk about the medical treatment options for feline hyperthyroidism. I encourage you to take a look at these learning objectives after we're done to make sure that you can sort of answer these questions for yourself and to make sure that you review, if you have to, you review what we're about to talk about. So, first of all, why and when do you do medical therapy? First, it's important to realize that you have surgery as an option, a thyroidectomy, and the thyroidectomy brings along with it, you need to have the skill, and you need to be able to avoid hypoparathyroidism, that is, preserve some parathyroid tissue, or you'll have hypocalcemia. The other option, of course, is radioiodine, which is actually, from a medical standpoint, preferred, but there are people who and owners who have a problem with the upfront cost of that or surgery, or they have they're not near a site that can manage the radioiodine treatment. So the advantage of using a drug is that you can demonstrate to the owner some improvement. And in an animal that's on average 13 years of age, sometimes the hyperthyroidism has been so debilitating to the cat that this is really a good thing to show them that this disease can be significantly reversed. You can titrate the dosages of the drug to avoid overtreatment, and that is avoid hypothyroidism. Of course, the disadvantages that are not curative. You will have to monitor the animal for the rest of its life with measuring T4 usually. Occasionally TSH is used, and they can relapse. The side effects are pretty common, as we'll talk about, and we'll go over those, but since the side effects are common, this can make it difficult for some cats to be managed easily with medical treatment. So what are the drugs we're going to talk about? Well, first of all, we have Methimazole, which is the prototypical Thioureylenes drug. Then Carbimazole, which is a prodrug, meaning it's converted to Methimazole, and it's used in Europe and Canada. And Propylthiouracil, also a Thioureylenes, but it is has fallen out of favor because of autoimmune hemolytic anemia and immune-mediated thrombocytopenia that it may cause. As we'll talk about, second-line drugs include radiocontrast agents, and the one that we're going to focus on is iopanoic acid that's used today. So starting more globally, I want to virtually say that along the hypothalamic pituitary thyroid axis and extrathyroid axis, or tissue, really the drugs that we're talking about here primarily have their effects either at the thyroid, that's at site 1 here, or they have it at the tissue level. That's there. And the drugs that influence the thyroid gland generally inhibit the enzyme TPO, thyroid peroxidase. And we'll go into more detail on that in the next slide. But the drugs that do this are the Thioureylenes drugs called Methimazole, PTU, and Carbimazole. As you moved into the main effect there is the reduction of T4 and T3 into the circulation and ameliorating the signs of the disease. The second side of action is at the cell, and so this is to inhibit the enzyme that you learn about in physiology called 5' deiodinase, and therefore reduce the conversion of T4 to T3. The drugs that do this are PTU, and that works on the type 1 deiodinase, and iopanoic acid that works on both type 1 and type 2 deiodinases. So the effects that you notice that PTU also works in centrally, so it would lower T4 and T3. Iopanoic acid does not work at the thyroid gland, so its main effect would be to lower T3 levels. So iopanoic acid also has another effect, which we would say is associated with a nuclear receptor antagonism, and so it tends to block that receptor, and that's the third effect. There's not a lot of evidence for that, but it's something to consider adding to the reduction of T3 in those animals. So let's look now at the inhibition of thyroid peroxidase. If you remember your physiology, iodine comes in from the plasma and moves through the cell, is taken up and into the colloid, and that iodine then needs to be added to tyrosine residues, and that enzyme involved in that is thyroid peroxidase. Thyroid peroxidase, by being inhibited, will reduce the amount of monoiodotyrosine and diiodotyrosine that are formed, and also that enzyme also seems to be able to reduce the linkage process to T3 and T4. So through this, you reduce the amount of T3 and T4 in the colloid, and therefore it takes a little bit of time for these drugs to act, but eventually that reflects in reduced secretion as well into the circulation. So let's first focus on methimazole, and the most important thing to remember there is that it's an inhibitor of thyroid peroxidase enzyme, and that at the right dose, and I've shown you some protocols here where you can get started, that you can normalize T4 in most of the animals. So that means that you need to monitor T4 over certain intervals, and I've listed those for you here. And the key thing to remember is that because methimazole does not work to reduce deiodinase activity in the periphery, the main effect you're going to see is that T4 will fall, T3 will fall, but it generally can be propped up again by an activation of type 1 and type 2 deiodinases in the peripheral tissue. So you'll see T3 often remains normal and that'll avoid some overt signs of hypothyroidism in that case. Let's take a look at the side effects of methimazole. Firstly, I'd note that even though it's the most common thing listed here, the autoimmune anti-nuclear antibody titers don't seem to be associated with clinical disease, so no disease like lupus. The most common side effects are going to be listed here that are characterized as GI side effects, and I'm including lethargy in that. So are GI effects most common. And the key thing about these is that these seem to be dose dependent, dose and time dependent. And so that means that you can sometimes reduce the dose enough to allow to manage the animal without side effects. It's the first thing to try. The other side effects, which is not dose dependent, are going to be those associated with allergy, and I would characterize pretty much all of these right here as allergy, drug allergy, and as I said, these are non-dose dependent. That means you have to switch drugs or switch therapies. Non-dose dependent. You could go then to the next class of drugs, or you could go to back to surgery or possible radioiodine if the Thioureylenes drug like methimazole doesn't work. So there's another mechanism by which you could administer methimazole, and this is the transdermal mechanism. So you have a compounded drug that can be given usually on the pinna of the ear in a cat to avoid having to pill the cat, and there's some advantages because of it. It seems to be efficacious in hyperthyroid cats. How it gets through the skin is not entirely clear, but it may be that there's a detergent effect, or it may just be that it's hyperthyroid old cat with thin skin. Nonetheless, it takes longer for it to have its effectiveness. You're going to monitor T4, and although GI side effects seem to be more limited by this mechanism, they're not avoided by the transdermal route, nor will you have any benefit in an animal that has drug allergy. So this is not an option for a cat with drug allergy. So not drug allergy. Let's take a look at the other Thioureylenes, and really just for historical purposes, PTU, propylthiouracil, is PTU. is working to inhibit thyroid peroxidase and also type 1 deiodinase. It's fallen out of favor because of autoimmune conditions like autoimmune hemolytic anemia or immune-mediated thrombocytopenia. Carbimazole was designed as a prodrug for methimazole, and it was originally proposed to have less direct GI irritation, which is probably true, but it's still absorbed and converted to methimazole, and it does have still some GI side effects. It certainly can cause drug allergies. A time-release preparation is now available that has allowed once-daily dosing. As second-line drugs, we have the non-Thioureylenes radiocontrast agents, and these are agents that are used to visualize the spinal column for CSF, not used so much anymore, and so this is the problem. Some of them have fallen off the market. Biliary contrast agent was Hyperthyroid, and that's now off the market. The one drug that is used still is iopanoic acid that I show you here. And you can see some of the similarities that it has to thyroid hormone itself. And so, as I said, its mechanism is primarily to reduce the iodinase activity in the cells, and it also may block the action of the drug at the nuclear level in the monitor T3. So what are our medical options if methimazole is not well tolerated? And of course, you can always go to surgery or radioiodine, but let's focus on the medical options. If you have allergy, you really have to go only to the option to go into radiocontrast agents, because all of the other drugs are in the same class of drugs. You could use the Hill's low iodine diet, but I'd point out that the data in peer-reviewed literature still has not come out yet to support this diet, and one of the concerns has been whether there are chronic problems with the drug in terms of treatment over long periods of time. So that evidence still awaits us. If you have GI side effects, you can reduce the dose, that's clear. Or you can move to carbimazole, which may have some reduced direct irritative effects on the GI tract, or you can use transdermal methimazole, but that also is going to still cause some GI side effects, but again, obviously there's not a direct stimulation. Chronic therapy tends to become more effective over time as you get an animal stabilized, so sometimes you can lower the dose and reduce the GI side effects. So in summary, we have methimazole is our prototypical drug. It's a thyroid peroxidase inhibitor, as all Thioureylenes are. The most common side effects are GI side effects. Some animals develop an allergy because this drug class has sulfur in it. It tends to increase the tendency for drug allergies. And then we have non-Thioureylenes drugs such as iopanoic acid, which can be used as second-line alternatives. And I want to add that in animals that are borderline renal function and hyperthyroid, there is the concern in some camps that you could have push an animal over the limit by reducing T4 values in hyperthyroidism and borderline renal insufficiency. I would encourage you to nonetheless treat the animal to normalize T4. Try not to make it low. Because clearly things like hypertension associated with hyperthyroidism are not good for renal function, may have been involved in exacerbating the overlapping normal incidence of renal insufficiency we see in older cats with this condition, hyperthyroidism. And I assume that it's not good for the animal to have the metabolic changes and muscle wasting, etc., associated with overtly or undertreated overt hyperthyroidism or undertreated hyperthyroidism. So the key to this treatment is to monitor very carefully to avoid hypothyroidism, because clearly there's evidence that hypothyroidism does reduce glomerular filtration rate. And that should be your goal, is to make the animal euthyroid, not hypothyroid.